Uh, just in terms of overall feedback, it was definitely keep keep giving us feedback because I hope you guys know that we definitely are very actively watching over like the webinars that uh, some of them I want to see more of you guys. If I do this, can I see more of you guys? The ones that maybe your guys are finding pretty okay and some that you guys are really liking. I'd say this was one that we got a lot more eights and nines and so good feedback on. So just I guess top of mind, anyone have like a top, does that be a top thought? A thought on the webinar, your experience of it, your takeaway and questions that it left you with? And if any, you could just either jump in or if you want to in the chat box.
So I took this very recently because I was behind, fully disclosure there. But I liked how bluntly he came to just the speaker came to just the subject of suicide, and even how he brought up that like not having a mental illness and suicide occurs. And just it had me thinking all day after I watched the, web Paycom learning thing, that just what that means and just kind of all the research that he said he was doing. And yeah, I was so interested in that.
Yeah, and good. In some ways, it's good that you just watched it because I watched it like a month ago and I'm like, I really like this. And then like 3 or 4 days ago, I'm like, what did I like? So then I listened to it again. So in some ways, doing it right before. So if some of you guys were more the early birds, all birds are welcome though. So you could be an early bird or late bird. It's all fine. But if anyone doesn't, I kind of brought, because I did listen to it again, some of the points that I was wrestling with too. So if you're sitting here thinking like, oh, I did really like it, but I just don't remember, we'll cover some of at least the areas that I stood out to me as noteworthier. And yeah, but does anyone else want to kind of jump in if you have any thoughts or maybe watched it recently? Susanna, I feel like sometimes like it's hard for people to jump in. As a co-facilitator, do you guys find it easier if you like raise your hand, put like a word in the chat box, and then we get to you? Like I have no problem just jumping in and talking too loudly, but I also know it feels kind of hard sometimes. So maybe if you have like a thought, like something that stands out about it, you could just put like something in the chat box.
Yeah, why don't we do that, since I know, ideally coming in with a thought or a feedback, and I definitely appreciate kind of your impressions. But yeah, this is, this topic is obviously fraught with a lot. So I wonder if, I think maybe let's take a minute and come up with, a word or a thought that you would want to kind of guide our discussion today. Could be on the, specific to the training, the topic overall, right? When working with clients you see here. So why don't we take a moment to do that?
Yeah. Like
I had a really quick thought, kind of just jumping off of what Anna was actually talking about while everybody takes a second to just put in a word. I was also one of those people that like, once I get the training, I do it right away. But then once we get to these meetings, I'm just like, oh, shoot, like, what was it even about? But what I do remember, because I also listened back to it, something that really jumped out to me, and I think you had it shown up on the slide, Dr. Kissin, is this idea that leading up to, suicide, like there's like this idea that like you have to get to this stage first and then this stage and then this stage, but that's not necessarily the case, and how suicide isn't always like a linear path. It's kind of the way that I kind of thought about it was the trajectory of like processing grief, of how like, people are often like, oh yeah, it's like a linear stages of, no, it actually like ping pongs between this and this and this. So I actually really liked that portion of this webinar of like, it can jump from thing to thing. There is no step to proceed that moves on to the next thing that ultimately, you know, leads to suicide. I really liked that piece of it. That one was really something that struck out to me.
Thank you so much. Yeah, in some ways, and some of the material I provided today, like it felt really like, obviously it's really scary and obviously it's really hard, but like, so what are we supposed to, like I put on the slide here, so over 50% of individuals who attempted suicide denied there was any ideation or did not mention suicidal thoughts. In some ways it feels like we're accountable for something that we can't control. But what I want you guys to know is we're not actually accountable. So legally, I think sometimes, of course, we care deeply about our clients, but then feeling locked in the oh no, what if I get sued? Or what if someone engages in this act and I missed it? And it's really important to know that, like, as long as we are doing what is clinically appropriate, like, we can't actually control what people do. In some ways, it lets me off the hook to really see that blatantly. Like, I'm gonna always try to do the right things and be there for people, and people still have free will. And it's really important to know that also, like, we're not an inpatient facility. Like, people leave places that are likely to get sued. Like, if someone is an inpatient facility where they're supposed to be in a safe zone and they do escape and harm themselves or find a way internally, but that's not our role in the mental health system. And people are going to know what they know and tell us what they tell us. So we just need to do the next right thing, but not feel so worried about, this is something I have the ability to control or prevent, because we really don't. And as scary as it is, the flip side is, because it's out of our control, like, it really frees us to just try to do the next right thing that we can do. I don't know if that makes sense, but I went from being scared by that to like, okay, so it truly is out of our control. Okay, so now we could get to the Susanna, do you mind? I closed the chat box. Can you just get?
Yeah.
Thank you so much.
Well, you started us out with interesting but challenging. And
Yeah.
then we have Dr. Bartlett. Did you want to speak to, you said it helped you with conceptualizing some of the clients that have had both suicidality and impulsivity. Want to speak to that a little bit?
Yeah, I mean, this is similar to Reza's point she was making, just that it's kind of taught to us in a way where there's like all these steps that kind of go in a linear model. And it really, for a lot of clients I've had, it hasn't showed up that way. And it's like, it's scary, like, to know there's not as much control as maybe it's taught. When we introduce suicidality and things like that, and I think in practice, like, it's made me, like, I don't know, frustrated that, you know, we do all of this treatment and then, you know, suicide ideation is still coming up, or, you know, there's still self-harm behaviors that are happening, and a lot of them are situationally based. And, you know, it's more of like environmental controls that, like, what's the next best thing, as Dr. Kissen was saying. And this just kind of, like, I guess, cemented something that, like, I guess, yeah, it just hasn't been taught in the past. And yeah, I was excited to hear about some of the research, because, like, I had heard, I listened to a talk, it was during this past year, and it was kind of similar. It was another psychologist who was doing research on this and talking about how we need to rethink how we look at it and how we address it. And looking at, you know, sometimes it is, you know, people who aren't necessarily outwardly struggling with mental health issues, or that sometimes it's people who are just in pain in their lives, like situationally. and just kind of meeting a client where they're at versus, you know, thinking about how do we prevent this thing that's sometimes out of our control.
Yeah, that's really well said. Yeah. It is nice to see some up-to-date research on it. You're right, because we learn it in a certain way and we know like about prioritizing safety, but it's important to consider all the factors, right? And that it's not always going to be linear necessarily. We also have, so Chris, difficult but necessary. Anything else you'd want to add on that? That's well said.
Honestly, that really covered most of it for me. It's just going through school and practice and hearing, you know, our responsibility to the patient to keep them safe, that we have these measures in place to assist us in doing that. When the reality is, if a client is determined to do this, they're going to do it, and we only have so much within our power to stop it. And I think it's very easy to internalize that as some sort of failure on our part when we have, again, all of these things that we're taught and all these responsibilities. I mean, we hear how many often we're a mandated reporter and we give the confidentiality speech at the beginning of every first session of we're going to report it if we feel you're a danger to yourself. And I think classes like this or modules like this help kind of put it into a better focus or a better perspective that while we are doing the best that we can, ultimately there is only so much that we can do. And that's not our fault, right? There's things we can do to help, there's things we can catch, but that's not always going to be the case. And I think doing our best not to internalize that and blame ourselves is a difficult thing when we feel we're responsible for safeguarding our clients' mental health.
Yeah, absolutely. I like that you speak to like the clinician experience too, right? And feeling like it's not, you know, not productive to internalize those things when you've done everything, you know, that you need to do.
Yeah, and I do think this is a topic for clinicians that it is really, 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 the definition of stress is when you feel accountable for something that you can't control. And we cannot control what another human being does, really ever. But I guess we're also not accountable. So that's something I want you guys to know is that, and I really liked what he was speaking about with the safety plan. In some ways, he didn't directly mention, he said there is some evidence that like not only safety plans not helpful, but it could be contraindicated. And I think the reason it becomes harmful is that when someone goes, they're in exquisite pain and all of a sudden you could tell when a clinician all of a sudden is like in cover my ass mode, it's no longer about them in that moment, but like, I need you to sign this form because I feel scared and I need you to do this. So I don't know if they're feeling shame, but definitely like emotionally abandoned in that moment of now I'm worried about me. And it's not my fault as a human or your guys' fault, but I think it's the way it seems in the industry as though then we're going to be in trouble. But that's what I want you guys to really understand legally. The flip side of that is like, that's not where malpractice claims come from for outpatient providers, therapists, you know, the occasional malpractice claim. One of the great lawyers who work with said, like, don't have sex with a patient. It was like very sort of like really basic old school. Oh, and then like very complicated divorces sometimes when people get very highly emotional, but it's not because we really can't control what people do. And so it kind of gives us the freedom. We've renamed, we don't call it a safety plan in the drive. We very intentionally called it a coping plan because there is something that can feel really bad when like, let's just create this safety plan so that I can feel better as a clinician that I have this document. Like I really want to have the intention with clients, like what can you do to cope in really hard moments?
Thank you.
So yeah.
Do you want to keep going with the chat?
Yeah, let's go in the chat box. Let's do it.
Sergey, I want to hear from you. screenings are far from perfect. Can you speak a little more on that? I really like that you called that out.
Yeah, no, absolutely. And I think, speaking towards, what Dr. Bartlett was saying, in addition to like Rez and kind of echoing everybody too, is just recognizing that it's really difficult to quantify something as complex as, SI, and just, putting that into just a document or, quote unquote, a safety plan of sorts, because, something as complex as that doesn't necessarily have, observable signs or those warning signs that we necessarily learn in a classroom or, hear in the textbooks or whatever it might be. And so I just think, and I appreciated the emphasis, within this module too, of the recognition that, although obviously screenings are there, they're supporting their guidance, they're used as guidance, they're helpful, but like with that, we can't just rely on those to be our sole determinant of whether or not there's somebody in danger or, thinking about that as well. To the point of like kind of what we were just speaking on with safety plans and changing, like how operations have changed over time. Like when I worked for United Way 211, like we used to have the no harm promise. Like that was something that like was initiated to where we would have to ask the individuals on the phone, like, do you promise that you will not kill yourself? Like that was something that was currently evidence-based for that time. It was in like 2019 or like 2018. And that obviously is nothing like not the case anymore, because that serves not to be effective in any way. And so I think it's so important to like stay on top of, new approaches, the evidence that's proven to be, effective, because it is constantly changing and it is super complex. So I just felt like, it's important not to necessarily rely on, those screenings as those sole determinants of risk or, underlying concerns.
Yeah. Yeah, that's such a good point. And it's, I like that you call it too. I'm kind of hearing a theme about, sort of theory, how things are learned or taught, be it it's, in school or through past positions versus like practical application, right? And that kind of a lot has changed. And I mean, I think it changes, that was a different time. It wasn't that many years ago. Yeah. Nicole, tell us more about kind of how you would apply this. Sounds like you have a client that, this helped you with.
Yeah, so I found this training pretty helpful, especially because I'm seeing a client right now who has had multiple previous suicide attempts that sort of she hadn't endorsed like, oh, I didn't have like intent or a plan before them. It was very much like a essentially heat of the moment attempt that I hadn't anticipated making before. So as I was watching this training, I sort of found myself like continuously going back to like thinking about her, especially looking at sort of this idea of like suicide leading up to a suicide attempt is not going to be a linear process for everyone. And like thinking about like the role of impulsivity and these other factors in sort of reaching that point. And it definitely like kind of informed how I approach those discussions about SI, suicidality. Like, of course, talking about like possible plan and intent, but also like I feel like it led me to think, okay, like this is showing up for this client, like is there anyone else who maybe like isn't experiencing plan or intent, but we see like that impulsivity showing up, or like potentially like in the heat of the moment, are we leaning more towards like suddenly considering this, even if it wasn't like something that's been showing up for us consistently, and sort of like integrating those conversations into like assessing for SI and like trying to best tailor it to the individual rather than like sticking to sort of this, I guess, not as updated model of suicidality that I'd sort of learned through conversations like in the past. I found like the updated research really interesting and really helpful. And I'm hoping that using like that newer sort of model will be helpful in like helping her to stay safe, like moving forward.
Yeah. Wow. It's great that you were able to, like, you kind of kept that client top of mind. Oh yeah, Dr. Kissing, go ahead, sorry.
Oh, no. This is like super helpful. I regarding just a couple things that came up through the comments. He mentioned the suicide cognition scale. And so I will have Susanna put maybe Susanna, did I send you the PDF of it? But we could put it with this webinar. And he was saying that had greater validity than just asking about suicidal ideation. So I was curious, what were the questions on the suicide cognition scale that did have better predictive value? So yeah, as we could see here, no one can help solve my problems. So hopelessness, I'm completely unworthy of love. Nothing can help me solve my problems, hopelessness. It's impossible to describe how badly I feel. I can't cope with my problems anymore. Anyone being able to withstand this kind of pain, there's nothing redeeming about me. I don't deserve to live. No one is slow. So yeah, deep hopelessness, self-loathing, feeling no change is possible. So just want to let you know, we will have that resource available. And there are, there's good tools in therapy notes, but if it feels helpful at some point to like do a screening with a client with that scale, we'll also make it available on Google Drives and Paycom.
Dara, do you want to speak to how this helped you a little bit? Your comment?
Yeah, I guess just what people have been saying about like what we learned in school. Like there's always that like feeling when you hear like, suicide come up or depression, especially when you're used to working with anxiety. It's like you kind of freeze and you're like, okay, I need to remember everything I learned in school and like do absolutely everything right. And I'm not as comfortable or familiar with this. So it was just nice to hear that it's like there's a lot of variables and it doesn't always have to be the same way. And sometimes even exactly what we learned in school is not helpful. So yeah, it made me feel a little better to approach it.
That's great. Yeah. Thanks for sharing that. I think it's like it's a lifelong journey with just feeling comfortable on it and learning more about it. Sounds like that was a really good thing to take from it. Dr. Kane.
Yeah, I feel like a lot of people have covered this, but just the understanding that there's not always going to be warning signs, and like Dr. Kitson was saying, kind of feeling a little not off the hook, because we still need to do what we can, but like not feeling guilty if something were to happen. If there were no warning signs, sometimes we don't have control over it.
And I think in some ways, I could think even it myself clinically and as a practice, sometimes there's a quick I don't want to use the word abandon, but they need higher level of care. Maybe it's someone who can't afford higher level care. They'd have to give up their job, but it feels like really dangerous. Oh no, if I support this person who is at risk of suicide, which any human being can be, like that's scary to me. And in the process, someone who genuinely deserves to be tended to, like often individuals who are experiencing suicidal ideation, like aren't treated because everyone's scared to treat them, when in reality, like that's not what will get us sued. And so I think sort of opening up a little bit more who I feel comfortable as a practice treating, because sometimes there really isn't a good place to go, but it just feels kind of scary. So Dr. Bartlett had a recent example of a client that, would I wish that she could have a higher level of care? Absolutely. She deserves more support, but at the same time, could that work in her current life? No. So we either like support someone with compassion who could benefit from our help, or just like, not it, too scary. And, I choose to be on the side of let's be there for people and do what we can do. And so it's kind of, it feels like that off the hook, no matter what, it's quite unpredictable anyway. But I think it just leaves people feeling more and more abandoned by the mental health system, because as providers, it just feels so scary.
Yeah, that's a great point.
I was just thinking too, like along that point, like it makes me think about the preteen clients and the teen clients that I've had who they're afraid or they hesitate to report when they do have suicidal ideation because they're afraid they're going to be sent to the hospital, or
and they will be, and
Yeah.
it's true.
Yeah, or they don't want to go to a higher level of care program, or receive an adverse reaction from their parents.
Right.
And like a provider would be just one more person who's giving them that reaction that
Right.
they're afraid of. So, yeah.
And it could be really traumatic, you know, like your parents looking at you with terror and sitting in the like these are really traumatizing experiences for someone who's already feeling really bad. Oy.
And Caroline, you had a point sort of related to that around this idea of passive SI, how it comes up more. I don't know if you had a particular population or people in mind, but I think that's, and again, to Dr. Barlow's, but it's really important that it's not sort of that. Ideally, you give them a corrective experience, but of course, you always have to still keep everybody safe. So it's very delicate. But I don't know if you want to speak to that.
Yeah. Yeah, I know I talked about it with you, Susanna, but I had a client like recently, like the first client who had some suicidal ideation and things like that. And so what everyone's saying about like kind of it's not our responsibility and things, very validating. So thank you for saying that. But I feel like I've seen it more in maybe the teen population, also with this specific client, but the idea of passive suicidal ideation, like, and it's not intrusive thought like suicide OCD.
Right, they really do yearn to die.
Right, but but they're like, and I know I would never do anything. It's such an interesting kind of blurred line, because it's like, okay, if you're going through the risk assessment with them, like technically they do check some of these boxes, but like this specific client has already been inpatient, like is transitioning out of inpatient. So it's like, okay, well, if we were to send them to the hospital again, right, it would just do the cycle again and again. So kind of, yeah, it just brought up like, what do we do with passive suicidal ideation? Because I think it's happening more and more. People are recognizing like, I am having these thoughts, but I know I don't want to be gone. I don't want to do that. It's just still there, right? It's in the back of their mind.
Mm-hmm.
It's really difficult.
And to jump in, I think sometimes the passive suicidal ideation, there's almost like a compulsion, escapist. It's sort of like rolling around in it, sort of like fantasizing about like an ex relationship, or even like watching TV to escape. There's a certain like it would just be so nice to not be alive. So like really just spending lots of time in that kind of thinking as an escapist, which doesn't help living your life to the fullest. Like any other compulsion of avoidance, like it does bring down distress in that moment to fantasize about not being in the current moment, but it also doesn't help figure out how to craft a life worth living. So in the like, what can we do? I just wanted to point out, I guess, so if we can't, there's a lot we can't control, but what can we do? Number one, what stood out to me was really like I really liked the example of in other aspects of public health, like thinking about the driving mortality examples that he gave. And so ideally you want to have maybe safer roads. Ideally you want to have at the pyramid of what has the biggest value, like safer road conditions, removing barriers really close to cars. And at the a little less helpful but still helpful are seatbelts, but then you have to also get people to train them to wear their seatbelts. So there's certain things that are just on a public health level and a society level we could try to do as humans to make the world a better place, but in our day-to-day work, that's not something immediately with each client that we can actually change the highway conditions, although we could be part of the world trying to make that happen. But with what we can do, kind of the seatbelt example would be the best that we could do, that removing means part of things. And I think for me, and I think I said this in one of the supervision groups, I always thought, yes, of course, you do that means assessment with people, what access to pills, knives, guns. But if someone wants to harm themselves, like, they're still going to do it. But it really is quite impactful. And he made the point of that barrier or that speed bump, that by removing the means, it gives them the time, maybe that moment's going to pass, because it comes on so rapidly, and it also could change form so rapidly that even if the knives are out of the house and you actually have to go buy a knife, or even if the pills are in a lockbox and you have to go get the key and the key is in the car, even those moments, it comes on so rapidly, but it also can shift so rapidly that anything that creates a speed bump, similar to body focus repetitive behaviors, like anything that's changing up the environment to make it the behavior more difficult to engage in, is going to give some time. And with that time comes the opportunity to do something different. So that kind of stimuli control really does, obviously it matters. So one thing, talking about handgun, talking about access to firearms and how lethal that can be, it occurred to me in our risk assessment, it doesn't directly ask about access to firearms. It does talk about access to, what is the drop-down menu? Risk factors. I think it just is access to means.
Means, yeah. It doesn't specify.
Yeah, our safety training, our risk assessment training did say, like, I just want to make sure we're always actively asking. I wish in the drop-down box we had that visual prompt of access to firearms, because it relies on us to, they're just certain people, like, I'm not always thinking, if it's a client who I've never talked about firearms with, and to always ask, and it's not part of the built-in assessment. So I really want to make sure that we're always actively asking, even if for someone who would think they don't have a firearm in their home, to always actively ask about that. So I just wanted to kind of do a shout out to remember to ask that. And then something, we're going to be doing a legal training in the next month or two. There's a training con that addresses steps to take if a client has firearms. And so this is a little bit out of my, we're going to have a lawyer coming to talk about this as well. But if we do have a client that is in immediate, there's very specific language, like they have to be clear and present danger, and they have a firearm, or they're thinking of getting a firearm, we're supposed to make an FOID report. So we'll have a lawyer that's going to come and speak about this. Has anyone heard about FOID firearm reporting requirements? It often doesn't apply in the outpatient environment, because if someone it's something that inpatient facilities, hospitals have to do very often, but most of the time, like, you really have to pose a clear and present immediate danger. And so for a client who's in that much danger, they should be an inpatient by then anyway. So for example, I once had a client who maybe was thinking she had access to firearms in her home. She was stating that she was so frustrated, she wanted to shoot a coworker, or maybe someone had this client. But we spoke with a lawyer and they said we still shouldn't make a report on that, because it wasn't immediate enough that we'd call 911. It wasn't considered a present enough danger. So he'll talk to us about that, but I did want to just mention, like, that's, as we're considering risk and access to firearms, also then considering who it wouldn't be safe to have access to firearms. So, and then I have a little bit of information about FOID reporting in here. But in terms of what else we can do, so number one, the risk assessment, access to means is really, really important. And then number two, it's really the work that we do. So I looked at the brief CBT protocol, and I know some people have asked about it. So Susanna found the PDF manual of it that's now going to be in Paycom. So the brief CBT, the protocol that he's referencing is really what we do. So it was helpful for me to see that what is the treatment that's effective is really CBT for anxiety and depression. So it's emotional regulation, it's behavioral activation, it's reviewing sleep, relaxation, mindfulness, coping cards. So we have the manual, but the way he was talking about the protocol, I was thinking it was maybe specific for, is there something different with suicide that we should be doing? And I was like, oh, it's really effective CBT for problem solving, behavioral activation. So the thing that we can do is what we're doing. So it made me feel better that there wasn't something like new under the CBT for suicide. It's like, how do you help someone to create a life that has less suffering and more joy and meaning? And so you guys are all welcome to look at the protocol because it was helpful to see, like, we're in good shape. So now, like, I just wanted to kind of run through those were my takeaways, and then Suzanne had people's comments and questions.
Thank you so much. And again, yeah, so I'll share those with you all, and I'll note where to locate them too after this. Allison, you had a point around sort of that mental health treatment was at the bottom of the strategies and like effectiveness. If you want to share more.
Yeah, I won't be too repetitive because Dr. Kissen kind of touched on this just now with the pyramid of strategies and how like eliminating means was at the top when it came to effectiveness, and actually just like all mental health treatment as a whole was kind of at the very bottom. So like including risk assessments, screenings, coping plans, safety plans, therapy in general. And it was just kind of like not totally surprising because I think we all are aware, again, like we've talked about, that we only have so much control, you know, if any, over what our clients choose to do, whether, you know, they have our support. And so it was just, yeah, it was just kind of validating, like some other people have said, to see that like we could do everything that the evidence is telling us to do, that we think that is right for our clients. And even still, you know, SI can happen, suicide can happen. And just to kind of release ourselves from that. Because I know like everyone who comes into this field comes in because we care about our clients. And so it can be easy to take that on. And then also like working within the systems that we work in, I think policies and things like that also put a lot on mental health professionals too, without addressing some of these other things that may be a lot more helpful and effective in addressing some of these things. Yet it kind of seems like it falls back on us because of just the way a lot of policies are written, and also that there's still so much that we don't understand about some of these things. So yeah, I think that kind of summarizes everything.
Yeah, I thought that's such a good point. The responsibility that you have inherently coming into the field, right? And then the feeling of an obligation and responsibility to the client and the larger kind of policies and best practices. It's a lot. Dr. Martinez Snyder, tell us more about your thoughts.
Yeah, so I thought that like kind of, I think Dr. Bartlett was the one that said it maybe, like hearing about like the research and stuff and kind of like the broader, you know, kind of like systemic things like in the training were definitely like really, really interesting. And like some of it was stuff that like I hadn't heard. So I think that was helpful, but it, you know, I think in all of kind of like my training experiences and, you know, since like there's been a lot of, as people have said, like I've been told different things by like different people. And part of that was just reflecting like, you know, what was best practice at that time, or, you know, what like previous supervisors were told was best practice, or having to follow like policies of agencies that are trying to like cover themselves and things like that. So I think for me, it's always just this like, just this like confusion, I guess, a little bit of like, I think I have a good understanding of what is best practice, but it's like kind of this, as people have mentioned, like a bit of a conflict between like, well, you need to cover yourself, but that might not be actually what's in the best interest of your client, and, you know, stuff like that, which is always just a challenge. Yeah, so that was just kind of like more my thought, was like anything related to like what really is best practice, because I feel like I've just got a lot of mixed messages over the years.
And I think those mixed messages comes with professional fear and not always from the wise mind of the organization or the supervisor. So like I just, when in doubt, do the next right thing. And I think it will take us where we need to go. And like when there's all the noise, like what is the next right thing that I can do for this individual? And like it's a shorthand, but it will work. And even legally, like, are we always trying to do like we can't control a lot of things and we can't predict what's going to happen in the future, but like, are we trying to do the next right thing? And I think it's hard to go wrong with that. So
yeah, and I appreciate what you said too, Dr. Kissin, about like the legal like side of things, because I think a lot of like these conflicting messages has been more, to protect like yourself legally, but then kind of implicit in that, or also some other messaging I've received, like especially early on in my training, was like, regardless of legal, it's like, it's still your fault as a clinician if your client like tries to kill themselves. And that's like, so I've moved away from that, but it's like, I did have the messaging of it, like, we're separate from legal. It's like, there still sometimes is this like I think Dr. Kane, you might have mentioned like a guilt kind of component or like something like that too. That's hard to separate because, as Allison said, we care about our clients, of course. So it's like trying to, I guess, maintain that boundary as well.
Yeah. We humans have the ability to control our own actions, and we don't have the ability to control others. We can help and guide, but we can't control. Susanna, take it for whoever's next. Thanks.
Yeah, well, I know I want to be mindful of time and get to everybody. So I guess I had a point that kind of connects to Brian's, just around something that's been coming up, which is the verbiage that we use, the language that we use, making sure that I always feel very cautious around that. And then specific to like what Dr. Kissin mentioned, right? A coping plan and what that might mean for someone, as opposed to what a safety plan might feel like or mean, or, differentiating SI from what could be harm OCD, those kinds of things. So that was sort of my 2 cents. But Brian, you had a point related around normalizing language, so would love to hear from you too, please.
Yeah, basically just really trying to get it out there and try to get them a little more open. I found sometimes, especially if somebody came from a higher level of care, they were so used to getting hit with a safety plan every day they checked in, that then they would just start minimizing it and not reporting it because they didn't want to deal with the paperwork. And so sometimes I try to, when I'm talking about it, I'll be like, well, do you have like, I'll explain what passive is. Like, oh, do you just have, you wake up in the morning, you just don't want to be here anymore, and just kind of bring it out there and let them know also that, I've had plenty of clients in the past that have experienced this. So to let them know they're not alone too, because that's another big thing, is a lot of people feel like they're the only one going through this. And I think even when we look at that, assessment that was just posted on the PowerPoint, it kind of shows that some of those questions really show how isolating it can be. So even just letting them know that I don't know, now I'm rambling.
No, that was really well said. It didn't seem rambly at all. Yeah, I like how you talk about it, and even like giving these, just that feeling, it is very isolative. And so kind of helping name it, and also knowing like it's not always going to be, I remember you mentioning at your last job, it would be every day you'd have to do a new plan. That can feel daunting. So I love that, how you spoke to that. Felicia, love to hear from you.
Yeah, so I echo what everyone else has already said about like navigating it as a clinician and feeling the pressure of being responsible, and also adding harm reduction into the mix and taking it from like that lens and saying like, oh, what do we have access to? How can we prevent access to that, or whatever it may be, and not beating around the bush and really naming what it is. Like, do you have this? Have you researched how many pills to take? And really like going in with it can be extremely helpful for people, and you kind of can throw them off guard, like, wow, like she's really asking me all these details. And then also what I mentioned is that calm training. It's free and it addresses like counseling. It's like counseling on access to lethal means is what it stands for. It's very interesting, and it talks about how you bring up the conversation about firearms and what you do when somebody says they have a firearm. And it sounds like Illinois has like a more specific plan as well, which is great. So that is very interesting if you are looking to get more insight about assessing for firearms and what to do.
Susanna, will you hold on to that? Because I would love to. I don't know how to speak.
Yeah,
I can send the
yeah.
link.
Yeah.
I can send the link. And yeah, I was actually curious. Like, thank you so much for bringing that to
Yeah,
us.
no,
And
that's really helpful. Thank you.
is that maybe show of hands? Is that something that the group would want to learn more? Or yeah, just nods. Okay, I got some hands. Cool. That's helpful for us. I'm gonna hold on to that. Thank you. And thanks for talking about the harm reduction piece too.
It's self-paced too, and it's really not that long. So it's pretty easy to digest.
Because I think what makes it hard for me is that I don't, as a non-gun owner, I don't know the language. I don't want to sound judgmental. I think someone deserves a speed bump to something that might cause them harm in the wrong moment. But I feel like I don't have the right words that I could sound like, oh my, get rid of your gun. So I would be so clunky. So I'm excited to watch that. Thank you, Alicia.
Sorry, bouncing around here. Wanted to hear from Lauren T and then Karen.
I think my point in there was kind of touched on already, and just we don't really have a lot of things that are in our control, but just preventing the means to do it is like the main thing that we can do as clinicians. I also had like a separate question. Is there like a manual or something that we could go through to have this kind of like in more depth and like how we can directly apply it with clients? I don't think like he went into like too much depth about like actually going through the process, but I don't know if that's available at all either.
The process of doing a means assessment, or the process of the BCBT, which process?
Of the BCBT.
We do, sorry, I switched rooms. We do have the manual. Susanna's going to put the PDF, or might even be with this training. And so you'll see the manual, but what's interesting is it's very much behavioral activation and cognitive flexibility. And so it's good to see, because you're going to feel like, oh, this is what I do. Okay, good. So in some ways, sometimes when something isn't new, it could be even better to see, because then it feels like it reminds you you're doing all the right elements. So yeah,
okay.
It's like a 160-page manual that Susanna will share.
Okay, thank you.
Yeah, thanks for mentioning that. Karen, did you want to speak to you were talking about the suicide cognition scale?
I think she stepped out to an appointment.
Oh, I'm sorry. Okay, well then we'll move on. Again, I want to get to everybody. Dr. D, tell us more about your thoughts.
Oh yeah. So just to give some context, I did my dissertation on protective factors and suicidal ideation in adolescent populations. So many resources that I don't know how to sum up in like a couple minutes. So
okay, good. We want the whole shebang. So
great. But I can just share a little bit about the thought that I said. So a lot of the research currently has showed that suicide in general has increased by 36% across the board from 2000 to 2018, which is pretty wild that despite all these prevention practices, like suicide is still on the rise. And so what my research really focused on was other factors or mitigating factors that can reduce risk for even having a suicidal thought. So it's kind of like protection, early intervention before someone starts formulating hopelessness, learned helplessness, suicidal ideation and stuff like that. And so I just attached a book on here, which I thought could be really helpful to learn more about protective factors. I don't know if anyone's heard of PACEs before, but it's basically like protective factors that support against ACEs, which I think most people are familiar with, like adverse childhood experiences. But new research is on PACEs, which I think is really awesome to learn about and use in our professional practice, because we can use these resources with any clients, despite if they're having any SI or suicidal behaviors, to make sure that they're living their most fulfilled life.
What's an example of a PACE? Like what's one just tiny?
Yeah. So it's kind of broken up into different categories. So they're basically broken up into like protective cognitive factors. So that could be focusing on distraction or problem solving. It also could be parenting styles, specifically in adolescence, or supportive factors. For example, having one best friend is a really great protective factor for preteens, or having like one trusted adult that you can go to is helpful for like older teens. So there's different factors that you can encourage within a client's lifestyle, so that way they feel more like mitigated toward risk.
So helpful, and we can't wait to learn more. That was really, really wonderful. I think we're almost out of time. Susanna, were there a few people that didn't have their...
I think we got to most everybody. Although Mary Grace, I know you had a point that if you want to wrap us up, that would be great.
Yeah, the last year I was working in the ER, the PEDS ER, so I did a lot of like suicide like risk assessments, and we had a pediatric ICU, so we got a lot of transfer patients too. But the hardest, it was like help affirming this training to see like a lot of it's impulsive in nature. So like inpatient care wasn't always elicited, because really what you needed was like IOP or PHP or outpatient care. And so that because they wait in the ER for a week, and then they get a week in an inpatient where, so it was helpful to affirm that. And then another training I did, it's like a CBT and family strength. It's called SAFE-DA. It's between UCLA and Duke, is like rolling it out, but it's talking about like the patient's strengths and then the family strengths. So it's like similar to that protective factor of really working on the family unit when like preventing these suicide risks or harmful behaviors or like self-harm. So it was a cool training to do because it did CBT and family stuff.
Hey, Grace, can you give us a